Hey, welcome back. Welcome to drug exam number 6. This week we are going to be talking about medications that are given for pulmonary edema as well as some electrolytes. So it's kind of a mixed bag this week. So you just started chapter 9. We're just starting to learn about acid-base balance. Know it's a lot. Know that it feels like it's overwhelming, but it comes to you. It comes to you. If you work hard, you will understand. So don't worry. So let's talk about some different medications that we would give to patients that are in pulmonary edema as well as some electrolytes. So what is pulmonary edema? Pulmonary edema is fluid in the lungs, and it usually is caused by heart failure, specifically left-sided heart failure. The left side of the heart can't deal with all the fluid, all the blood, and the blood starts to back up. The blood becomes fluid in the lungs. So we have to figure out a way of getting that fluid out of there. And suctioning is not going to work for us. So we're going to have to go a different route. We're going to have to get that fluid out of the lungs and back into the circulatory system so we can get rid of it. And speaking to get rid of it, the first medication we're going to talk about is what it is a loop diuretic. What that means is that in the nephron, it allows for more urine to be produced, therefore getting rid of the fluid in the form of urine. So if we give somebody a loop diuretic, about 20 minutes later, they are going to have to pee, and they're going to pee a lot. And dependent upon the amount of diuretic we give them, they might pee a tremendous amount of fluid. We also give Lasix, and Lasix is another diuretic that we give for patients that are having fluid overload, too much fluid. Typically, the dose for this medication is zero point 0.5 to 1 milligram IV, given slowly over 1 to 2 minutes. It works pretty quick, and it can cause some problems usually associated with decreasing fluid levels. So hypotension, headache, those types of things. It's a great tool when you need it, but you just don't want to make them get rid of too much. The next medication we're going to talk about is nitroglycerin. Now, I'm sure you're probably familiar with nitroglycerin, and you're probably thinking, Tony, why are we talking about nitroglycerin in we're talking about pulmonary edema? Well, what do we know about nitro? We know that nitro is a powerful vasodilator. So what that does for us when we have a patient that has pulmonary edema, it allows us to have a more of a container to push that fluid out into. So we use CPAP, and CPAP puts pressure into the lungs, it inflates the alveoli, and it allows for the transfer of that fluid from the alveoli back into the circulatory system where the kidneys can get rid of it. So we know that we give nitroglycerin to patients that are having chest pain because it causes vasodilation that hopefully will promote more circulation and blood flow to the heart muscle itself. I'm sure you remember one of the side effects is a decrease in blood pressure. And that is, in this situation, we have to remember we can't give nitro if they have a systolic under 90. And I would even be really careful giving it to someone with a pressure of 90. And when I say 90, I don't mean 90 exactly. I'm talking 90-ish. If your patient has a blood pressure of 92, that doesn't mean, bam, just get it. You've got to think about it from a different point of view where that's a soft blood pressure. And nitro is going to drop the blood pressure. So even if they have a blood pressure of 92, 94, you're probably going to dip under that systolic blood pressure of 90 after you give them medication. But understand, nitro works quickly, but it's also gone quickly. So you can give nitros every 5 minutes because it's in and out of the system very quickly. So just remember that nitro also is sensitive to light. So that's why when you see the nitro bottle, it's not a clear bottle. It's a dark brown bottle because nitro has to be kept in the dark so it doesn't decompose. Now the dosage for nitro is 0.4 milligrams sublingually, and it depends on where you work. Some agencies carry nitro pills, some agencies carry nitro spray, and there's even a nitro paste that kind of looks like toothpaste that works transdermally that we can give to patients. Because we'll talk about that more when we talk about giving nitro in cardiac emergencies. But just remember that we have to be careful with soft blood pressures when we start giving someone nitro. Calcium chloride. The next two medications we're going to talk about, calcium chloride and calcium gluconate. Now, they are used interchangeably in the hospital. If someone has hypocalcemia, they can give them calcium to replace it. But calcium chloride has 3 times more calcium in it than calcium gluconate. So calcium gluconate is good because it doesn't cause some of the problems associated with calcium chloride. One of the big concerns with calcium chloride is an infiltrated IV vein. Calcium chloride is very concentrated and it can cause tissue necrosis if given to a patient and it leaves the vascular area and goes into the tissue itself. So you got to be really careful with it. Remember that it is an electrolyte and the dose is 500 milligrams to 1,000 milligrams IV push for hypocalcemia, hyperkalemia, and those types of things. But please make sure that your IV is patent before you consider giving calcium chloride or calcium gluconate. It's not a medication you can get very often at all, so don't calcium gluconate, like I said, it's an electrolyte just like calcium chloride is. And it's the same dose is given, and it will it's a little bit smaller of a hammer than if calcium chloride is a big hammer, calcium gluconate is more of a small hammer. Mag sulfate. Now, if you remember back a few weeks ago, we talked about mag sulfate. We're going to talk about mag sulfate this time for patients that have torsades. And it is an electrolyte, just like some of the other medications we are talking about. We can give it for hypomagnesemia if the patient has that, and that's what we're talking about at this time. Is for someone who has low magnesium levels, we can give mag sulfate via the IV drip. And that dose is 1 to 2 grams in an IV solution given over 5 to 60 minutes. So it's a pretty wide range of how fast you're going to get it. It can cause central nervous system depression. Remember that it is a powerful vasodilator. So it can also cause hypotension. And we give it also for respiratory emergencies where we need to open up those those airways. But one of the main things we get is torsades. And we'll learn about torsades in the second semester when we talk about cardiology. Sodium bicarb. Sodium bicarb is a hydrogen ion buffer. It causes alkalosis. So you're just learning about acid-base balance, and either 7.35 to 7.45 is the normal range for your pH in the body. And if you have somebody who is acidotic, they fall below that 7.35, they might need something to help them compensate and get back up to that normal range. And we give sodium bicarb for that. Usually, we will give the patient 1 milliequivalent per kilo. Maybe sometimes we can repeat that if we need to have that dose, but it works very quickly. And it's really given for several different things, all involving acidosis.